Hello and welcome to today's Curing Coma Awakening Hope webinar. Today's webinar is addressing an important medical and societal problem presented by the Program Manager for the Curing Coma campaign, Len Polizzotto. And I will now turn it over to you, Len.
Thank you. Coma is a serious medical issue. The Neurocritical Care Society has embarked upon a bold initiative, and that is the Curing Coma campaign, whose purpose is to identify the detailed biological mechanisms underlying coma and to develop new treatments based on these new learnings. This effort is being run as a rigorous, disciplined program with teams that have tasks, milestones, and objectives. Coma can be considered an acute form of disorders of consciousness. This is where the patient is unresponsive to external stimulation. It is usually due to a failure in the thalamo-cortical interactions or in the reticular activating system. Causes include traumatic brain injury, lack of oxygen to the brain, seizures, infections, and drug overdoses. Coma affects a broad ecosystem, including patients, family, physicians, nurses, therapists, and hospital administration. We have to create value for each member of this ecosystem for whatever solution we come up with and new treatments, so that each one of these members of the ecosystem feels that they are being created value. Not only the patients, but for the physicians, the nurses, and everyone else who has to deal with the new techniques. Coma is costly. TBI alone accounts for over 55,000 deaths. And withdrawal of life support to coma patients in the ICU accounts for 70% of these deaths and 40% of those with hypoxic ischemic injury. And overall, the societal cost of coma exceeds $75 billion. There are compelling questions about coma. Will the patient wake up? If so, what will the alertness level be? Can a comatose patient fully recover? How long will it take? How complete will the recovery be? If in a prolonged coma, should life support measures be stopped, and if so, when? There are gaps to answering these compelling questions. They include, we really don't know the biological basis of consciousness. We don't have accurate patient assessments to understand the details of the type, location, and where the coma is occurring. We don't have good prognostication for what the patient outcome will be, and we don't have the appropriate treatment protocols. So identifying the primary issues in finding a cure for coma include identifying the right problem. So the problem is not curing coma, but the problem is, if coma is so important, why hasn't it been solved today? A lot of smart people working really hard. And we call this the key insight into why coma has not been solved. What has prevented it from being solved? That's what we have to understand and get at. We have to understand the scope of research needed to address the problem. We have to understand the capabilities that are currently available and what new ones are needed. What resources will this take? What barriers exist? And those barriers could be technical, but it also could be administrative, political, emotional, many forms. What are the risks and how can they be mitigated? And eventually, we have to develop an action plan with milestones. Why has not coma been solved? One is the lack of the ability to accurately identify the type and location of the defect. We said the defect is in the reticular formation or in the corticothalamic connections. We need to know where the defect is, the nature of the defect. If you think of this as a circuit, where in that circuit do you have either a short or an open? And can this circuit be improved or corrected? We have a lack of diagnostic tools that can really understand those issues of wear and to the degree of the defect. Another issue is workers working in silos. Many of us are incentivized by what we do as an individual. Have we first authored in a paper? Have we come up with new IP? Yet to solve an important, difficult problem as Coma, we really need to work as a team. We need to share and build off of each other. There really, to date, has not been a dedicated multi-institutional team effort. One institution just doesn't have all the resources and capabilities to solve such an important problem. There's been a lack of appropriate funding. There hasn't been an overall project champion, someone with passion really pushing to make this happen. And again, there really has not been a clear problem definition. And again, defining the problem is what has prevented Coma from being solved today. So this is a bold initiative. And again, launched by the Neurocritical Care Society. The Curing Coma campaign is addressing all these critical issues. And we're using project management as a way to really make this happen. So if we want to be innovative, which is what's required here, we really need to apply innovation techniques. A good book on this is The 5 Disciplines of Innovation by Carlson and Momont. And they define 5 criteria which are critical to have something innovative. One is, are you addressing an important problem? Well, that's clear. Coma definitely is an important problem. Do you have a value creation process? And earlier I mentioned we have to create value for all these stakeholders in the ecosystem. This includes, how do you build upon each other's ideas? How do you iterate with one another? How do you give each other feedback? And we are doing that. Do we have a champion? We sure do. We actually have 5. Doctors Hemphill, Olson, Provencio, Suarez, and Vespa. Do we have a team? We do. We have over 30 intensivists, nurses, and researchers that are part of the effort. And are we aligned with our overall organization? Sure are, with the NCS, since they have sponsored our program. So our approach is to have rigorous program management to ensure that folks are on task, meeting their deliverables. We have defined technical tasks. We have communications with different organizations to make sure everybody's informed, and we have the appropriate teams. So from a program management standpoint, overall, we have mission control. These are the 5 leaders of the overall effort. Doctors Hemphill, Olson, Suarez, Kim, and Mayanelli. We have a program manager to make sure everybody stays on task. We have an executive committee of 6 folks, the 5 champions that we mentioned before, and the program manager. We have a steering committee that adds another 6 folks of experts to the executive committee. And finally, a scientific advisory council of over 30 folks, all experts in their field, willing and able to participate in this important effort. So some of the details of the overarching technical task was really important to understand what we're trying to do. The first is endotyping. And that is defining the detailed nature and location of the cause of coma and the recovery trajectory. Possible 4 subgroups. One, that there's no structural damage in the paths that we talked about, and it's amenable to therapy. 2, that there is structural damage, but amenable to therapy. 3rd is structural damage not amenable to therapy. And 4th, structural damage that mimics coma. And through a deep dive science, understanding what's going on at a molecular level is how we're going to try to define these 4 different subgroups of endotypes. The second big effort is around biomarkers. And we need biomarkers are important to determining the precise physiological indicators of coma for each specific endotype. And we need the development of tools, preferably non-invasive and ICU user-friendly, that can locate the source of and measure and monitor the coma biomarkers. We need proof of concept clinical trials, which are rigorous endotyping prior to enrollment. So we know where we're starting and where we're going. And the goal is to seek consciousness promoting therapies. And finally, data analytics. First, we have to set up a common shared database that everybody has access to and conduct things such as prospective studies and existing database analysis. So the deliverables, the short-term deliverables for these technical areas. For endotypes, we want to develop clinically and biologically relevant coma endotypes. And we want to identify which endotypes are amenable to treatment. For the biomarkers, we want to identify the anatomic and biochemical pathways for coma. And we want to correlate these endotypes with clinical outcomes. For the clinical trials, we want multimodal tests of predictive and pharmacodynamic biomarkers. And we want stimulation therapies that attend to reactivate brain networks. On the communications front, we've established a common language. The first example is the fact that we are calling the details of the coma endotypes. We have CDEs, common data elements, for standardization of the data. We've just had a white paper on these efforts, most of which I've described here, that has been accepted in the Journal of Neurocritical Care. We are scheduling World Coma Day. We've established a website. We conduct regular meetings with the various groups, and we're in constant dialogue with the NIH and other agencies. From a team standpoint, we have diverse teams, both technically and geographically, which is very important. So folks from Europe, Asia, including the United States. These folks are passionate and dedicated. They really want to solve this problem. They're domain experts, but most importantly, they're team players. And what I mean by that is they're willing to work together, share ideas, build off one another, and throw away their egos. Absolutely critical to success in a difficult problem like this. In terms of how we work together, we've established a teaming agreement that we're ready to implement that lays the ground rules of everything from IP to publications. We're working hard on giving and taking each other feedback, and to understand that feedback is a gift, not a criticism. We're constantly iterating with one another and building upon each other's ideas. We're embracing diversity of views and capabilities. And most importantly, we're doing a lot of sharing of credit, data, ideas, IP, and facilities. And it's through this sharing that we're going to accomplish good results. We're watching out for what we call the big A, or approach. And what this is many folks address a problem based on what they're good at, as opposed to defining what the real need is that has to be solved. Okay? We see this over and over again. And we're making sure that we define what the real issue is first, then leverage people's capabilities to see how we can apply it to solving that problem. Our current status, 8 modules with 5 activated, from engagement to community collaborators, member sites, prospective database, coma data science, expert liaisons, implementation science, and investigator toolkit. And we have 7 working groups with identified leaders have been formed that have established milestones and objectives that include deep dive science, common data elements, prospective studies, existing data analysis, database development, communications, and fundraising. So going forward, we have rigorous, regular reviews of milestones and deliverables. We're adding expertise to fill any voids we may have in capabilities. We're providing regular updates to the NCS, NIH, and other agencies. We're planning to make World Coma Day an annual event to continue the awareness of this important problem. And we're constantly seeking funding to make sure we're not resource limited. Thank you.
Thank you for attending today's webinar presented by Len Polizzotto, and thank you, Len, for presenting. If you have any questions, please contact the Curing Coma campaign at curingcoma@neurocriticalcare.org. Thank you and have a great day.